So good morning, everybody. I'm Supriya Besbarwa. As you know, I lead on risk communication and community engagement for WHO Southeast Asia region. And I'm very pleased to have all of you here because we have some excellent panelists talking about something that's right now very, very close to most of our hearts, I think. How can you get communities to wear masks? We have there's some research was done in rural Bangladesh on convincing communities to wear masks. It was done by an interdisciplinary group, social scientists and public health specialists from both the US, from Yale and Stanford University, and from Bangladesh, IPA. And we have 4 of those team members today, led by Mushfiq, who you've just heard. Mushfiq Mubarak is from Yale University. He was the founder of IPAC. YRISE, sorry, YRISE, which looks at innovations. And he's also a member of the Jamil Poverty Action Lab. And he's one of the 3 PIs leading this research. And so we're very fortunate to have him with us. We also have Ashley Stikzinski from Stanford University. And from Bangladesh, we have Shadman Rahman, who's a senior manager in IPA. Unfortunately, the country director of IPA, Muhammad Afral Haq, could not make it due to a family emergency. We're all, have the same issue here in this part of the world, but we have some very good panelists here. And Laura Kwong, is she here?
She's in Uganda with spotty internet, but she might join.
Great. So without any further ado, because I think the panelists are the best people to talk about their work and what they've done and what we can learn from them, over to Mushfiq.
Supriya, thanks very much for hosting. Thanks to WHO for organizing this and for inviting your very extensive network in all around the world. And I just wanted to quickly check, and can you see my full screen slide?
We can.
Yes, okay, great. Okay, so we're going to talk about some research we've been doing for the past few months on how best to convince communities to wear masks. That's number 1. And the second associated research question is, once they do wear masks, what happens to COVID transmission? And so today we'll focus on stage 1 of that research, which is something that we all are curious about, especially in South Asia as cases are escalating, is how best to change community-wide mask wearing norms. And so this is a project that did require many different teams and people with different types of expertise to come together. So, first part of the project is all about behavior change and how do we convince people, persuade people to do something that we think might be good for them, right? And the team from Yale, so Jason Abelak, who's also in here, and I led that team. And then especially for the second stage of the research and what happens to COVID transmission. So there's a team from Stanford Medical School, and Ashley will be representing that team today, and she will speak she will talk us through the results. The funding was directed by GiveWell, which is based in San Francisco. Innovations for Poverty Action is an international NGO, but they run randomized controlled trials. So those of you who know JPAL in India, IPA serves a pretty similar function. And then Green Voice in Bangladesh were the main implementers. It's a small NGO, but with an extensive network of volunteers around the country. And A2I is our window into government. This is the innovation agency within the Bangladesh government. And through them, we work with the DG Health, the Director General of Health, right? And so I represent Yale YRISE, and BRAC has, in our scale-up phase, BRAC is now playing a critical role. BRAC is a very large NGO in Bangladesh. And so we have this is what we ended up doing. We have a very large scale study to evaluate both how to get people to wear the mask, and as well as the effect on transmission. So it was a clustered randomized control trial that I'll describe, and the clusters are villages. So there were entire villages or communities that received a series of interventions: mass distribution, free mass distribution, information, then follow-up mass promotion, working with community leaders, etc. A package of intervention, and it was given to everyone in that community. We looked at we are looking at community and individual rates of COVID infection. We worked with multiple kinds of masks in different villages. We tested a portfolio of about 20 different encouragement strategies to see what works, what doesn't work, because our goal is to identify the precise combination of strategies that are necessary and sufficient to get sustained increases in mask usage. And so this was done at very large scale, where there's close to 350,000 adults that are in our trial, spread across 600 villages in the country. Okay. And so a poll, so Neela, if you could reshare maybe the link.
Yes, I've just reshared the link, so you should see it.
So if we could ask you to please fill out, like take just a couple of minutes to fill out the survey. The survey just asks you a basic set of questions on, which gives you a clue as to what we did. And then the question is, do you think, what do you think happened when we did this? So we'll just come back later, we'll show you the results, and we'll come back later to compare what we actually find relative to what this set of eminent audience here thinks that we found. And the reason this is useful for us to do, I mean, not only to make this session a bit more interactive and have you more engaged, but also because, we are now working on scaling with various governments, state governments around India, provinces in Pakistan and in Bangladesh. And it's useful for us to learn, what are the results that people might find more surprising? What are the results that people might find more obvious? Because that helps us tailor our message to our government counterparts, to our decision-making counterparts. So that's the reason we're having this. So I will just say a couple of as you're filling this out, just a couple of additional things. So ultimately, this research will answer the question, how do we get people to wear masks? And then answer the question, okay, once we did get people to wear masks, did this reduce COVID transmission rates at the community level? Okay, does it reduce infections? Now, so this stage is taking some more time. So this stage 2 requires us to collect blood specimens and then test them for seroprevalence. And currently, with the nationwide lockdown in Bangladesh, we just, by the skin of our teeth, before Ramadan started, we got our all the tests done, and we are now figuring out how we have all the blood specimens collected. Now we're figuring out how best to test them given the lockdown that the country's under. So then we don't have results on this yet on what happens to COVID-19 transmission. So sorry to disappoint those of you who are more inclined toward the medical science and the public health. But if WHO invites us back in a couple of months, we'll be able to share that. So today, we're going to focus much more on like what your poll is about, which is, okay, what strategies, how did people react to the strategies we use to try to get people to wear masks, right? So number one, can we get them to wear masks? And the second question that's very important to us is whether or not mask wearing inadvertently leads to some compensatory behavior. So for example, early on, our conversations with some of your colleagues at WHO in Europe suggested that there was a worry that, look, we don't yet have great randomized control trial-based evidence as to whether masks work or not, right? Which is actually the main reason we conducted this study, okay? And so we don't have that great evidence. And what if people get a false sense of security that once I wear a mask, I'm okay, so now I don't have to worry about social distancing, and then we inadvertently actually hurt the communities, right, by making them less careful about COVID. So therefore, in this trial, we also track that. So what types of spillover effects are there of getting people, encouraging people to wear masks? Okay, so let me see how we're doing with the poll responses, if I've given you enough time. Now, we have quite a few responses completed. So let me then move on. And okay, but please keep them coming. Okay, so why are we doing this? So number one is that it is important for us to get evidence on whether or not this is a good idea, because as I just said, that there were a lot of critics who were worried about that mask wearers might engage in compensatory behaviors, which might be bad for public health, right? And another reason to talk about masks today and continue to do this work is that while vaccinations may represent the end game for COVID-19, right? Although it's not clear yet, given the mutations, etc., right? It's still the case, even if these the vaccines that we currently have on the market end up being extremely successful in tamping down COVID-19, it's still the case that low-income countries are a year or more away from large-scale vaccination. I mean, even India, which is a large-scale vaccine producer, right, has not been able to inoculate much of their population. And you can imagine many other low-income countries are way farther behind, right? And therefore, other non-pharmaceutical interventions like masks, I think, are going to continue to play an important role. So therefore, it's important for us to figure out how do we get people to wear masks, right? And that has been a challenge, as it has been a challenge for many public health behaviors. So for example, it's been a challenge for us to get people to use toilets, like improve sanitation. It's been a challenge to get people to adopt improved cook stoves, right? And we're facing a similar challenge here. And then one of the main goals that we were talking about today is what are the most cost-effective combination of strategies that we can use in order to get people to wear masks. Okay. All right, so now that we have your responses, let me give away a bit of the results, right? Just to tell you up front what the bottom line messages were, but later Ashley will come in and talk you through the details of these results. So the first thing is that the combination of strategies that work, that involve free mass distribution and some follow-up promotion activities, the combination of those things, we were able to increase mask usage by about 30 percentage points, which represents more than a tripling of mask usage. So in the control villages, we're measuring everything in terms of proper mask wearing, like this gentleman is doing here, covering your nose and mouth. In the control villages, this type of mask wearing is only practiced by about 13% of households. And this is all based on direct observation after we ran our interventions. But we were able to get that up to 42%. Okay, and this was not just a 1 or 2 day effect, just like a novelty factor of running these interventions. This impact was sustained 10 weeks into the trial, right? So basically, this 30 percentage point increase was more or less consistent in week 1, week 2, week 3, all the way to week 10. And importantly, the 10 weeks represents a period, includes a period after we finished our intervention activity. So it's not like it decayed very quickly and the effect went down to 0 as soon as we left. People continue to wear masks. That suggests that social norms probably are playing a role here, and some new norms have been forming. Okay, and then this worry about compensatory behaviors, it turns out we find the opposite, which is when we do this mass promotion campaigns, that increases physical distancing, doesn't decrease it, right? So it's not that people are engaging in compensating behaviors, it's more that once you do mass promotion and you start talking to people about the importance of protection, they start doing a whole set of activities that are good for public health, both mask wearing, but also other things like distancing. And then we learned some practical lessons from our trial. So surgical masks, which are much cheaper, right? Even though the government and experts in Bangladesh we talked to in advance were all worried that surgical masks would not be widely accepted by the population because they're viewed as like a one-time use cheap product. What we actually find in the trial that these are just as likely to be worn and used as the cloth masks, right? And they're much cheaper. So this is one way for us to actually get masks out to large numbers of people very cost effectively, right? And then another thing that we learned is that mass promotion was an essential complement to mass distribution. So you cannot just freely distribute masks and walk away. When we did that, that did not have sustained increases in mask wearing. We have to follow up and ensure that these masks are being worn by visiting these villages periodically and doing some monitoring and reminders. And so here's a graphical representation of the combination of strategies that work that we think are critical, right? So the first one is door-to-door free mass distribution, which we did door-to-door at houses, right? That was our first point of intervention at people's homes, right? And as we were doing these door-to-door distribution, we were also giving people information. So through brochures and a little video that we showed them. And the video did include, endorsement messages from the Prime Minister of the country, who kindly recorded something for us, the director of the Imam Training Academy, who kindly recorded something for us, and maybe most importantly, Shakib Al Hasan, who's the best cricketer we've produced in Bangladesh. So there was endorsement by sort of well-known leaders, okay? So this was what's happening at the house. And then we also learned that doing some mass promotion activities at mosques, which is a place that people gather and stand shoulder to shoulder, especially for Friday prayers, that it's important for us to run some activities there, which is doing some supplementary mass distributions there. But on top of that, in advance, working with the imam of the mosque and his team, getting them to endorse the idea of mass wearing, and in fact, giving him a pre-prepared script for him to read out while he does the sermon. Okay, so those are the things that happen in the mosque. And the third point of intervention was at markets, which is another place that people get together at high density. And this is where we had people with megaphones and reminding people to wear masks and doing some additional distribution. And this is the part of the treatment that turned out to be critical, which is that we go back into the villages, say twice a week, right? And if people are walking around without masks, we walk up to them, these mask promoters, like one or two of them, mask promoters walk up to them and say, oh, we distributed masks, where is yours? Why aren't you putting it on? And if they're close to their home, if they forgot it, like, can you go back and get it? But if that's not convenient, then the mask promoters did carry some extra masks and gave people replacement surgical masks. Okay? So we did try out the intervention without this component, and it didn't work nearly as well. So this component turned out to be a critical complement to mass distribution. Not only do you need to freely distribute, you need to follow up and make sure that they're being worn. So this is what that video looked like. So these are just clips from the video. And we did a whole series of activities, brochures, videos, posters, the imam speech, audio recording, etc. So all of this, and some done at household, markets, and mosques, and some done only at one place versus another. And beyond what I just described, we also tried out a plethora of added strategies. So we looked at in advance of designing the trial, we looked at the literature in economics, like behavioral economics, development economics, in marketing and psychology, right? And looked at what are the strategies that experts are telling us based on other research in other sectors like sanitation or stoves or agricultural technologies. What are the ways that we can promote adoption of new behaviors and technologies? And we tried out many different strategies that come out of that literature. So for example, part of that literature says, text reminders might be useful. Okay, so we tried that. So we ran that experiment where some households and in some villages, they received text reminders to wear masks, right? And then some psychology literature suggests that if you get people to first make a verbal commitment when you hand them a mask that yes, I'm going to wear it, then they're more likely to follow through, right, with that commitment. So we tried that and we tested whether or not that led to increases in mask usage, right? And then some other literature suggests that it's about social norms. So each household needs to signal to their neighbors that, yeah, mask wearing is good and we're doing it, right? So basically, once we got a commitment that you're going to be a mask wearing household, we gave people stickers to put on their walls to signal to their neighbors and friends that they're mask wearing, right? And then there's other literature in economics that suggests that sometimes incentives are important. So you go to the villages and we talk to the leaders and say, look, if we get increases in mask wearing rates in this village, we're going to come back and give the village a monetary reward, right? And in other villages, we did a non-monetary kind of a government issued certificate as a reward. And so this is motivated by examples like open defecation free signs in villages in Bangladesh and India. Right? So we tried that as well and we experimented with that, and we'll see if that works or not. Right? And then the type of messaging, like, when we're giving people information about wearing masks, sometimes we emphasize the self-protection benefits of masks. Sometimes we emphasize the altruistic motivation for wearing masks. It's not about protecting yourself, but protecting your friends and family. So we varied that to see if one message versus another was more persuasive in getting people to wear masks. So we experimented with all of this. And the reason we could do all of this is that we had this very large sample size of 350,000 people. So that gave us lots of room to maneuver and try out different things in different places and still have large enough samples within each bin to be able to make statistically precise statements about what works and what doesn't work. Okay, okay, so now I'm going to turn over to Ashley to talk through mask design and then talk through the results. And Ashley, if you want, you can take control of the screen, or I can just click through if you just tell me.
I'll just have you click through. Yeah, that'd be great. Thanks. So for the decision around what types of masks to distribute, we distributed both cloth masks and surgical masks. The cloth masks, we optimized the design based off of particle filtration efficiency testing that we did to verify what the performance would be of locally available materials. It was important to us that these could be produced at scale locally and could be made to be within our price point. So using available materials, we found the best combination of what we could use was a 3-layer mask, cloth mask using 100% non-woven polypropylene as the outer layer, and then 2 layers of interlocking knit. And this gave us approximately a 35% filtration efficiency at a 0.3 micron particle size. So the reason why we tested this is because this is the most penetrating particle size. However, the caveat should be noted that we don't actually know the particle size that carries the most virus or that leads to the most infection, but this was the most rigorous standard we could observe and we could test. So for example, droplets are much larger than 0.3 microns, so the blocking ability of these masks is going to be much higher for particles that are larger or even smaller. We also found a local manufacturer of surgical masks who could produce these at scale for our study. And this is a pretty standard surgical mask that has the 3 layers of the non-woven polypropylene. And this performed at about 95% filtration efficiency at the 0.3 particle level. So you can see that there's a huge difference in performance, but the question remains as to, does increased filtration efficiency offer greater protection? And so this is something that we really wanted to evaluate. So we distributed both of cloth and surgical masks to different villages. Next slide. And the way that we evaluated uptake of mask wearing is through direct observation. And we defined mask wearing according to whether masks were being appropriately worn, meaning covering the nose and the mouth. We also made note of whether participants in the study or in the village were wearing either our specific project masks or any other masks. Those also counted as mask wearing. We did not count people inappropriately wearing a face mask or people who, of course, were not wearing any mask at all. And simultaneously, we observed the impact on physical distancing by determining whether people in public spaces were standing at least 1 arm's length away, or approximately 3 meters from another individual. And you can't differentiate whether people standing next to each other in the market are from different households or not. So we made the assumption that each individual was an independent household. Next slide. So now we'll move into talking about some of the results. So one of the first things that we determined was that free mask distribution and promotion more than tripled mask usage in all locations. And so on the next slide, we'll talk about how that looks by location type. So we can see the overall effect here, where at the baseline, you saw about 13% mask usage, and in the treatment villages, it went up to 42%. So of note, we continued to observe this throughout the intervention period. So we know that there was no change in the control group. Oh, previous slide. Thank you. And that effect was similar whether we looked at markets. Mosques had slightly higher uptake, and then other locations such as tea stalls were slightly less. Go to next slide. We also noted, importantly, that this mask use increased wearing behavior was actually sustained 10 weeks into the trial. And why this was important was that the most intensive mask promotion happened in the first few weeks, and then it was more sort of a maintenance level of promotion thereafter up until week 8. So at 10 weeks, we would have ceased our promotion activities. And so it was notable that without this, that we still saw increased mask wearing among the treatment groups. And so here's a graph just demonstrating what that looks like over time. You can see that that level that we saw, the 29 percentage point increase, was held pretty much throughout the entire observation period with no change in the control villages. Next slide. So overall, we were able to say that free mask distribution and promotion increased physical distancing as well. So dispelling some of the concerns that this would lead to compensatory behaviors, we actually observed the opposite. So overall, we found that there was a 5 percentage point increase in physical distancing. This was true to an even greater extent when we looked at markets. However, in mosques, we were unable to change that behavior, likely related to ongoing traditions and rituals about standing shoulder to shoulder. And so we were not able to see an effect there. Next slide. And when we observed in terms of preferences, whether people preferred surgical or cloth masks, we found that they were just as likely to wear a surgical mask as a cloth mask. And this was an important finding because some feedback early on was the concern over that surgical masks would be not very durable and that people would be less likely to reuse them. We did try to counter this with a sticker that was placed on the mask, noting that surgical masks could be reworn and even washed. And this was based off of testing we did with partners in Mumbai at the Tata Institute for Fundamental Research, where we washed masks 10 times. And we saw that the filtration efficiency of the mask slightly decreased from about 95% to about 70 to 75% after a single wash, but did not further decrease after subsequent washes. So it was still more effective than the cloth mask in terms of the filtration efficiency. And also just the subnote there is that the surgical masks were much cheaper than the cloth masks to produce. They were about 1/3 of the cost, and about half the cost of that surgical mask was related to that sticker saying that they could be washed and reused. So if you're not producing that sticker, then they would be even more inexpensive. Next slide. And so what we found, though, was that the mask promotion was an essential complement to the free mask distribution, that it wasn't enough, and this is based off of some of our pilot data, it wasn't enough just to distribute masks, but also promoting them. So this slide demonstrates that. So you can see in pilot 1, where it was primarily about the distribution of the mask along with some role modeling and advocacy, uptake was very modest. In a second pilot we did where we added in-person monitoring, that the uptake improved substantially. And so that ended up being the basis for our intervention, where we saw a similar improvement in mask wearing. Next slide.
Yeah, so going back to the poll that we just conducted, right? So I just looked at the results that came in. There were about 20 responses, and there was wide variation in people's views on what happened. And just to tell you what exactly happened is that when in question number 1, when you said we provide free masks to all households and promoted mask wearing in mosques and markets, so that was basically our first pilot. And there we saw an increase of about 10 percentage points, right? And then when we added to this, the mask promoters periodically monitoring, it goes up to 30. And then when we added all these other things, such as like having the mask promoter be accompanied by the village police, the chowkidar, right? That did not have any additional effect, right? So that suggests to us that this is not due to some fear of some legal sanctions, right? The effect that we saw from like adding the mask promotion and the reminders, it seems to be more due to some informal social sanction, meaning like it's kind of awkward for you to have this conversation with somebody who stops you and says, oh, where's your mask? And you put it on, right? And there's a little bit of social shame associated with that, and that's sufficient to get people to change their behavior, right? And then when we added the text message reminders, right, no additional effect. When we added the signage and verbal commitments, no additional effect. When we added the incentive payments, no additional effect. So all of those add-ons that I had on a slide, right? So basically what we learn is that those things can be safely avoided, because like when you're trying to implement this, adding these things can be complicated and expensive. It adds to the intervention complication because you need to maybe coordinate with the village institution, like the police institution, or you need to actually monitor mask wearing in order to make the incentive payments. But you can forget about all of that because just the basic package that we worked on was sufficient, right? And then finally, right, did mask proportion change physical distancing, right? Yeah, it actually increased social distancing despite what the worries were like last year when people were critics of mask wearing. Okay. So I want to move into sort of much more about the implementation now. So we were careful to collect lots of data on how much this cost us to do, right? So we basically figured out that even though it was a relatively costly way for us to run these interventions, because we were trying to conduct a randomized control trial where you have to treat treatment groups and control groups separately, that requires extra supervision of workers and enumerators so that there's no messing up of what's treatment, what's control, and sort of spillovers from one to the other. So even with all those excess costs, this cost us about $2.5 to $3.5 US dollars per person that we treated, right? I mean, that includes the mask cost itself, the door-to-door distribution, plus the promotion and the follow-up activities, the working with the imams, the working with the community leaders, all that put together, right? And so that, given that cost, so basically per village, it costs us about $1,500 to $2,200, right? And we can combine it with data on the best guesses from the literature on like how much do masks reduce transmission by, right? So we take, how much did we increase the mask wearing rate by, multiplied by how much does mask reduce transmission, and how much does lower transmission reduce COVID fatality, right? Given the fatality rates, right? We put that all together and we can estimate what is the cost per life saved. And at the low end with the surgical masks, we think it costs us about like $28,000 to save a life. And that's actually, like, for those of you who track these numbers on the cost of life years saved, etc., this is a really good deal, right? Because even the willingness to pay to avoid a statistical death in Bangladesh is way above this number. So that's one way to think about, whether this is an efficient investment, right? Another way to think about it is that the main policy tools in government's hands right now is that you can do this kind of mass promotion that we just studied, or you can go for lockdowns, right? And given the increase in mask wearing rates that we see and the decrease in transmission, right? So we think that our mass promotion campaign is kind of like a quarter of a lockdown, right? By looking at like comparing our work to the estimates of how much does transmission get reduced when you impose the lockdown. So it's a quarter of a lockdown, but it's much, much cheaper. It's much more than 4 times cheaper, right? And so once you think about how much a lockdown costs based on the best estimates we have from macroeconomists on like the reduction in GDP and economic activity due to lockdowns, you see that if you were to try to get this reduction in transmission through the mass promotion rather than lockdowns, you can actually save a lot, right? So essentially, maybe it's not an either or, but what you can do is if you can do effective mass promotion, then the lockdowns don't need to be as stringent and as long lasting. And that's how you would save money. And lockdowns are actually very expensive for the economy, very expensive for people's livelihoods. So if we can find good ways to avoid it, right, and still keep COVID transmission low, that would be an important win, especially for low and middle income countries, right? So we think that you'd save about $1,200 per village. So this, for an average state in India, maybe an average district in India, this represents, like about $3.5 million of savings per month in terms of avoided lockdowns, okay? And further, these are all numbers that we're telling you on the basis of how much it actually cost us to run this intervention, which was a little bit more expensive than what we would normally have it at scale. So then we also talked with our implementers and talked carefully through, okay, at scale, if you were to order masks in much larger bulk orders, if you were to use mass media rather than do very careful individualized media campaign and showing people individualized videos rather than using WhatsApp or rather than using social media, just because we were trying to do an RCT, keeping treatment and control separate. So if you can, forget about like at scale, forget about all those details and safety with respect to the experimental protocols, then we think we can reduce costs by like 60 to 70% further, right? So this gets a lot more cost effective, and this becomes a much more attractive investment for countries and for states. Okay, so we already talked through this. Like when you think about implementation, like what we learned, the main thing we learned from this trial is that in rural communities and smaller towns, right, where your identity for the community, your neighbors, and what they think of you, etc., all matters, right? So this is a set of things you have to do. You do have to do free mass distribution, but you have to follow it up with these other types of activities. Okay? And what we learned here was, mass promotion, not only free distribution was critical. Social sanctions were sufficient. You don't need formal legal sanctions. We did learn a lot that people, in a lot of different ways, that people seem to prefer surgical mass, and it's also cheaper, so that's a win-win, right? We learned through like the process we went through that local leader engagement was critical. We also learned that, aesthetic preferences matter. So for example, the color of the mask that we distributed, we also tested different colors. It turns out some colors are much more likely to be worn than others, right? So we also have to think through like what are local preferences with respect to aesthetics, right? And then all these different kinds of nudges and incentives had no added effect, so these can be safely avoided. All right. So Shadman, do you want to tell, Shadman is at Innovations for Poverty Action and was kind of our boots on the ground who was closest to the village level implementation. So do you want to give us a few lessons on what challenges you saw and how you overcame them?
Yeah, of course. Thank you. So because of the pandemic, we had a few extra challenges in our implementation. For this project, we had to ramp up and hire 700 staff all across Bangladesh very quickly, which was a challenge during the pandemic. This is where the involvement of our partner Green Voice was very important. Green Voice, as we said, has a network of youth volunteers all across Bangladesh, which we use as a hiring pool. Because of this, we were able to hire locally, so our officers did not have to travel very far during the pandemic. Where possible, we hired people to work in the villages where they lived, because they were already trusted by the community and were able to engage members more effectively. We thought this was a good approach to take. Finally, we also actively tracked COVID symptoms among our officers and tested regularly to make sure everyone was safe during the pandemic. Another challenge we
Go ahead.
So, we already discussed this a bit. And another challenge we faced was that there was a perception that surgical masks were disposable, so they could be just thrown away. And so we had some special messaging. We had a map of Bangladesh and some text printed on the surgical masks, and we had some scripts associated with it, which to convey the message that we could wear these masks multiple times. We could wash it, and this is a special kind of mask, basically. Yeah.
Well, I mean, it's also important, especially given the escalating rates, that we are careful about the people who are the facilitators and the enumerators and the promoters who we hire, that we keep them safe, right? And we're happy to report that like we kept track of this, and people had access to testing and they had access to paid sick leave, right? But during this entire intervention, following the safety protocols that we had, we were able to get our job done safely without compromising the health of the people who worked on the team.
And sorry, Mushfiq, if you can just go back to that slide just to call out a couple more things. The third point is, I think, getting the community buy-in is very, very important. And so what we discovered was that it wasn't so much the elected leaders that were important. It was really the informal or social leaders, the members of mosques, the market committees, locally respected elderly. And it was particularly important to get youth and female leaders to reach out to youth and women. So that was really important. And that's where the Green Voice Network really helped. And you can see that a lot of this was multiple conversations even before the intervention began. So the promoters went, I think, Shadman, a couple of times, every time to the mosque, right? Every time there was a promotion. So that's really important. It is very much a community promotion.
So Shadman, do you happen to know, there was a question in the Q&A, how many of our promoters or staff actually got sick with COVID while they were doing this job?
No one got sick. We had, I think, 4 or 5 cases where we had a survey where we tracked symptoms. We had 4 or 5 people who showed some symptoms, but upon testing them, no one got sick, luckily.
Okay.
So
Yeah, so that was Rubaiyat's question. So yeah, we ended up distributing 1.2 million masks, but given the various safety protocols we followed, we were lucky enough that nobody got sick during this period. Okay. And let me actually, given that we're at 40 minutes, I'm not going to go through any more details, just to say that we've been thinking carefully through like ways to reduce costs, because right now we're at a stage when we're trying to implement and scale up this program through various implementing partners, like building the coalitions that are necessary in Bangladesh. And we've been having these same conversations with, in fact, we just got off a conversation with the State Health Secretary for Gujarat. We're having the conversation in Telangana, in Bihar as well. And then in Pakistan, we started with Punjab province and then moving to other provinces from there. And in each case, what we're trying to do is, look, we have a set of, we now have a set of lessons from the research that I just talked through, but we also have a lot of sort of implementation details that might be helpful for our partners, right? So we're trying to create something like a toolkit, both in text form and video form, so that partners who want to implement these ideas in their state or province, right, that we have a package ready to go. And the second thing that's become clear to us is that, when we are talking about implementing this program effectively, there's a series of activities that have to be jointly done, right? That you do need to do some pre-implementation training. We need to procure masks, right? And then we have to do door-to-door distribution. And then we have to do the promotion. We have to have staff on the ground who can go work with the community leaders and get them to endorse the concept and get their support, right? We have to send out these promoters back into the villages periodically to go and monitor and like remind people, please put on your mask, right? So there's a bunch of different activities here about mass procurement, mass distribution, then promotion and follow-up, right? And we think that, depending on the state that you're in and that you're working in, that there may be different organizations that may have different comparative advantages in getting that done. For example, in Bangladesh, securing the official permissions, that's really in the wheelhouse of the government, right? Even mass procurement at large scale, the government can really help with that because they might have some leverage over, say, garment factories or that can produce masks at large scale and do it quickly. But on the other hand, the government may not be particularly well suited to do all the door-to-door campaigning, and there BRAC comes in, and they are much better suited because they have much better presence. They have offices in every district and sub-district, and they have much better local presence to be able to do it. So we're trying to figure out, right, like in Bangladesh, what is the coalition that we need to form in order to solve all these problems together? And that's the same process that we're going through in our discussions right now with various states in India and provinces in Pakistan. And so if this seems to be of interest to you or to clients that you're working with, we do have, we are trying to put together all of the material that will be helpful for implementation, right? And we're happy to answer specific questions about that. And then we are also thinking carefully through, okay, what exactly are the types of places where these results apply, like the concepts that we've identified, right? So it clearly is most applicable to rural areas where the same sense of community that we're talking about, like the sense of shame that comes from, interaction between people and who your community is in terms of your friends and neighbors, right? It works probably in small towns as well, depending on the community structure. Like the set of ideas we're talking about is not necessarily relevant for big cities because what gets people to change their behavior in a big city, given that the identity of the community, the nature of the community, the definition of who matters to you all changes. So we have to think about, in that case, what we've learned from this project is that, look, mass distribution is not going to be enough. We need to do these follow-on activities to encourage people to change their behavior. But we have to think carefully through, in a city context, how do you change behavior, right? And we're happy to, be your thought partners in thinking through that. Okay, so I'll leave it at that. And my email address is on here as well as Neela's. So please feel free to write to us and reach out. So I'll leave the slide up here for a while. And you can, and we'll share these slides, but if you go to this URL that's up there, you can also download the slides for yourself. And maybe we can move into a Q&A.
So there were a few questions in the chat, and I can call out the participants in case they want to sort of add to that. So Sophia Lonapan, I think her question was, how many masks were given to each household or each person? And was this a repeated exercise of providing the free masks? Second was, were people in, so that was the answers, I think 3 masks per household, but correct me if I'm wrong. So how many masks per household, is that a repeated exercise? Second, I think there are a lot of questions around homemade masks, cloth masks versus the surgical mask. So were people encouraged to make homemade masks? Was there a particular design of the cloth mask that was promoted? And a third question is, how do you define markets?
So Ashley, would you like to take the question about masks, and then maybe Shadman, you can take the question about definition of the market?
Sure. For masks, we did not necessarily promote homemaking of masks, but we promoted wearing of masks, of whatever masks people had available, or the ones that we had just given them, depending on the context of where the observations were taking place. Certainly, making of cloth masks at home is one way for people to kind of be empowered to protect themselves. However, without having any standardization of materials, you can get a huge range of filtration efficiencies, so very different levels of protection. So many people will use a handkerchief, for example, which provides almost no protection. And so one of the things we wanted to do was to make sure at least the cloth masks that we were giving out, we could verify the amount of protection that was coming from them, because in markets and home production, a lot of the ones that are the most comfortable to wear, especially in hot, humid climates, offer the least amount of protection. So that wasn't a big part of our agenda beyond just general mask promotion.
I have a question here for you as well. When you talk about masks, you distributed the masks, but did you find that there were people who had masks but didn't want to wear them? And how did you convince them to wear them? Because that's an issue we face here. People have masks, but they just don't wear it. I noticed that you also, tweaked with the design of the mask, and I was wondering if that is one of the things you did to make.
Right. So go ahead, Ashley.
I'll let you go ahead.
No, please.
Okay, so the design of the mask was also meant to sort of maximize comfort as well as reduce the amount of leakage around the mask. So there was efforts into specifically choosing a design. And this was also based off of discussions with people in terms of what designs were the most comfortable, which ones didn't suck in when you're breathing, for example. So there was some thought into the design as well. In terms of previous ownership of masks, I'll just say that from prior observations, we know that masks are very prevalently available and at different times of the pandemic have been worn by a larger sector of the population. But at the time we began our study, mask usage had definitely dropped off. So it wasn't that masks weren't available and weren't widely owned by many people in the population, even prior to our intervention. But if Mushfiq or Shadman have more to add, I'll let them.
Yeah, I can add to the, So we did find, we have a lot of anecdotal evidence that the promoters found a lot of people who had a mask, but they weren't wearing it. Upon approaching them, telling them, oh, where's your mask? Or, talking to them about our messaging, a lot of them would put it on. So I think a lot of it was less the availability of masks, but just the promotion needed to happen to do the behavior change aspect of it.
Okay. Yeah, I mean, there's a lot of questions around wearing masks properly in the Q&A. So let me just add, just to give you some color as to what happened here. Right? So in terms of the mask design, we have to be careful about it in that, what happened in the design process was from, say, an engineering lab at Stanford, we had very specific specifications on what material should be used for the mask, how many layers, etc., such that it maximizes filtration efficiency, right? So that, based on those specifications, we gave it to a number of different garment factories. They created prototypes, right? Then we took a bunch of prototypes from many different factories, put them in a FedEx box, shipped them to Stanford, got them tested, and figured out, okay, what subset of masks are performing well, right? So then we identified that subset. And then we did a lot of focus groups and pilots with those masks to see what people found comfortable, uncomfortable, right? So that's what happened in the design process. And then in the information we gave along with free mask distribution, there was a lot of emphasis on making sure people understand what proper mask wearing means in terms of covering nose and mouth, right? And then, in the areas where we gave out surgical masks, right? There was a concern, oh, this is a surgical mask. This is something I can buy on the streets and it's really cheap, right? But we could actually show them physically, like, look, our surgical mask has these multiple layers. So if you hold it up in the light isn't getting through. But if you take those cheap masks, you see that light gets through, right? So, I mean, you could visually, like, not that that's the most scientifically accurate way to describe the difference, but that was something that was salient for people, and it was easier for us to convince them. And then every time we did the follow-up promotion activities, there was emphasis on wearing mask properly, which is it has to cover the nose and mouth. So the when I say that awkward conversation is partly people are not putting on their mask, but partly it's also that when they're not putting on their mask properly, we remind them to do that properly, right? All the information, like the brochures where we had pictures of, oh, this is what an improper mask wearing looks like. This is what a proper mask wearing looks like. So we did, really emphasize this over and over.
Thanks very much. So, so what you're saying is it's essential to keep reminding people, explaining to people how important it is to wear the mask properly.
Yeah.
And from what I gather from your presentation, that is key.
It is.
Making a difference. Okay, over to Neela then for the other questions.
Yes, so there were some questions around sort of the duration of the intervention. How long was the duration? And then, what was the extent of observation? So when you observe people in the markets, how long did you observe them for?
Yeah, I could take that question. So the duration of the intervention was, I believe, 8 weeks for the total. A lot of the promotion happened at the beginning, in the first 2 weeks, and then it tapered down. In terms of the surveillance, is what we call them. We assigned a person for each village who visited over the course of the 8 weeks. They visited 6 times, and it was a whole day assignment basically. So they started early in the morning. They went to the space, the public spaces, basically where the most people gather, so the most crowded public spaces, and they sat in a corner, very inconspicuous, and they just marked down like the total number of people they saw for every person, if they're wearing a mask, like if it's a proper, improper mask wearing. So basically they went to all the spots and they spent an hour at each of the locations. So for example, like say a village has a lot of people, it's very busy during the morning where people go to the market. This person went to the market, observed for 1 hour, and then moved to the next crowded space.
And I see a lot of chatter in the chat window about like surgical versus cloth masks, right? So I would say, here's what the research team would tell you, that based on the various types of research we did, including mask filtration testing, etc., right? We are big fans of surgical masks now, okay, for the following reasons. So number one, the filtration efficiency starts out at much higher. So basically the material that's used for surgical masks, because of the static as well, it does much better in protecting you from the filtration efficiency is a lot higher at the beginning. It's at 95%, whereas at cloth mask, it's at low as 40%. Okay. The second thing why we're a big fan is that you can keep hand washing the surgical masks and reuse it, right, for a longer period than people thought. And after even 6 to 10 washes, the filtration efficiency goes down to maybe 70%, but that's still better than what the cloth mask starts out to be, right? Third reason is that over time, we learned that people seem to prefer the surgical mask. It's just less intrusive, less uncomfortable, etc. Right? So I think that's the way we would go. But having said all of that, if we're having this conversation in Gujarat, with one particular implementer, and they're like, oh, we have a whole bunch of women in our network who are making cloth masks already, right? And so my reaction to that is, look, some mask is better than no mask. If you already have cloth masks in your possession, please go ahead and use it, right? We don't want the perfect to be the enemy of the good.
And I think we just have time maybe for one or two more questions. I just want to reiterate this point. Do the findings indicate that supply of free masks and behavior monitoring over a long time are essential to sustain the behavior? maybe taking the over a long time part of the
Yeah,
question.
so I think we can be very precise about exactly what the time period is. So the first 2 weeks is a set of intense activities, right? We need multiple staff members to be visiting the village. And the reason is we need to do the free mask distribution door to door. And while we're doing the door-to-door distribution, we need to provide a lot of information, including proper mask wearing information, right? So that takes time for us to get through the whole village. And we need to go into the village and talk to the local leaders, right? Talk to the imam, visit him again, and talk to the imam's team and make sure that through repeated conversations that they fully endorse our ideas, right? And they're our partners in making this happen. So there's 2 weeks of really intense activities that's required. And after that, we do another 6 weeks of additional work, but that's much more light touch, right? Which is we're visiting the village once or twice a week, right? And in fact, if I had to bet, I think doing, maybe 8 weeks is not necessary, right? A fewer number of weeks would be fine. Okay. So yes, so I would say the answer to the question is free mass distribution is not enough. You do need to do the follow-up, but that follow-up can be relatively light touch, right? Basically, you send somebody into the village and they only spend like one person spends only 1 day in the village. The next day, that staff member can move to a different village. So it doesn't have to be very intense.
And just one sort of final question, maybe you can talk a little to is differences in subgroups. And then a question related to that is, should it be universal mask distribution or should it be to the most vulnerable or low income groups? And subgroups, specifically gender, age, did we see any differences?
Right, since we think that social norms matter a lot here, right? I would, and also because of the fixed cost of like distributing things, right? You go to a village and like the cost is in getting to the village, right? The additional cost of a mask is very cheap. If you take a surgical mask, it's like 6 cents a mask, okay? So I would think that for most implementers, it would be most sensible to just do universal mask distribution. The logistical reason is that the marginal cost of giving it to everybody once you're already in the village is not high. And the substantive reason is that if you really want to develop social norms, you don't want to give anybody an excuse, oh yeah, I did not receive a mask, right? You want to be well known in the entire community. Everybody received a mask, everybody should be wearing it.
So Supriya, I think, yes, I'll turn it over to you. I just want to say that in closing that we are preparing an implementation toolkit with all of the protocols, the media collateral, the video that we talked about, the posters, and also the health. Some of you asked questions about health and safety. So some of the health and safety protocols that were followed, and it should be ready in a few days. And we can also provide the link for that to adapt any materials.
Thanks very much, Neela, and thanks very much, Mushfiq also. I know we've reached the end of our time, and I know that Mushfiq and Neela and all, you're up really late. It's what, 1 o'clock at night there? So I'm really impressed by how coherently you've managed. But may I ask one more question? This is regarding what you mentioned about women and using women leaders to reach out to women. What was, what was your findings regarding increase of mask wearing if you have a gender breakup? Do you have?
Yeah, we did look at the gender breakdown of mask wearing, and from what I remember, and somebody correct me if I'm wrong, the mask wearing rate among males was a little bit higher than among females, right? But something in the order of like 5 percentage points higher, right? Like 3 to 5 percentage points higher, where the overall effect was at 30. So we're talking about, like say 33 rather than 30 is the effect size, right? And this is partly, this is also rational because men are, in rural Bangladesh, men are spending more time outside the home compared to women, right? So it might be more, like habits are easier to form and you're always going outside the home and you're always having to wear a mask. I think that's probably where it comes from.
Oh, okay. Oh, Jason's also.
Okay. So Jason says it is higher for women, but increased more for men. Okay.
Okay, that's interesting. And how was it difficult to reach women and teach them how to wear a mask properly and sort of sensitize them, considering the social structure?
Shadman, what do you think?
Yeah. So actually, like when we went to the household, when we visited households, we were visiting mostly during the weekdays, for example. So of the people we reached, around 65% of them were women. So a majority of the people in the household that we spoke to were women. And so it wasn't too difficult. They were able to understand the message, and we don't have any. It seemed like it was equally useful for both men and women.
That's interesting to know. Thank you so much. Thank you very much to all the panelists for an absolutely fascinating webinar, fascinating findings, and all the best with the next stage of your project, which will be really, really interesting as well. I'd also like to thank the two persons, Jason, who didn't speak today, but also I know played a very important role in this project and has been answering questions. Thank you so much for joining as well. Deeply appreciated that you're here late at night just to speak to all of us, because this is really very important for our region, for all the countries. I'd also like to thank the participants for taking time off. I know you're starting your work day, but you've still made the time to listen in. And I hope we can move forward on this area, having understood what works, and more importantly, what doesn't work. It's a big step forward. And I'll work with Neela and make sure we share all the presentations, and forward to being in touch with all of you. And all the best for your project. Thank you very much.
Thank you.
Thank you. And I'll just say in closing that, this research team believes strongly in the importance of mass, especially in South Asia, where we're now faced with a horrendous problem. And we stand ready to help whoever would like that support.
Thank you. Thank you very much. We will share this video as well, distribute it also to a lot of people who wanted to be in this webinar but couldn't make it for various reasons. Actually, it shows the situation here. Many of them also had illnesses as well. So we will distribute this video widely to everyone who wanted to be here as well. Thank you very much.
Thank you.
Thank you.
Thanks, Supriya. Thanks, team.
All right. Actually, this is